Hello, everybody. My name is Graham McCourt. I'm the Global Key Opinion Leader Manager for Adult Ventilation for Via Medical. As you all know, we're running a series of webinars on the latest thinking on treating patients. We've been very fortunate to have world experts, and today's world expert is Professor Jordi Mancebo from Barcelona in Spain. For those of you who have been involved before looking at studies or clinical trials, the name of Jordi Mancebo is very famous. He's well known, well published, and is involved with many multi-center studies. And I think that today's topic of mechanical ventilation and protecting the ARDS lung is so important. Welcome, Jordi. It's good to have you with us again. And it's, of course, a great honor. And may I ask you to say a little bit about your hospital and so on, and your interest, and then please continue.
Thanks so much, Graham. It's a great pleasure to be with you all, and I thank you very much for this opportunity to share some knowledge about ventilation, mechanical ventilation in the ARDS patients. My name, as Graham told you, is Jordi Mancebo. I am the director of the intensive care department in the University Hospital of Sant Pau in Barcelona. And my main interest is mechanical ventilation, invasive and non-invasive, acute respiratory failure, de novo hypoxemic patients in COPDs, and also weaning of mechanical ventilation. And I'm proud of being the co-author of a number of physiological, clinical, and some randomized clinical trials that are related with the whole issue of mechanical ventilation. So in the next 40 minutes or so, I'm going to discuss what we can do to protect these injured lungs of patients with ARDS. These are my conflicts of interest, and these are the contents of the presentation. First of all, I briefly talk about the magnitude of the problem, the ARDS. What about the setting of tidal volume, the settings of PEEP? What about proning? And finally, some words on the controversy regarding whether or not COVID-19 ARDS is similar to traditional ARDS. And I'll finish with the conclusions and some recommendations. So we are going to discuss patients with lungs like this. This is a plain chest X-ray with full-blown ARDS. This is flooding of alveoli by edema rich in proteins, which occupies the alveolar spaces, so that's decreasing the total gas amount of the lungs, and thus decreasing compliance, and also generating intrapulmonary shunting of blood, which explains the hypoxemia, typically refractory to high concentrations of oxygen that these patients have. And this is not the most recent data on epidemiology of ARDS. This is the LungSafe study that was conducted in 50 countries around the globe. And here you can see that the magnitude of ARDS is not negligible at all. So, it represents up to 10% of ICU admissions and more than 20% of patients requiring mechanical ventilation. So this is a huge amount of patients, so a huge potential for doing good and doing harm. And also quite worrisome in this study, it was the observation that the clinical recognition of ARDS was, I would say, poor, and ranged between 50 and almost 80% of those cases. Well, now, when patients with ARDS need intubation of the trachea and invasive mechanical ventilation, apart from FiO2, there are two fundamental settings that need to be adjusted. One is tidal volume, if you use volume control ventilation, or if you use pressure control ventilation, you will need to adjust a level of pressure above PEEP to generate a certain amount of tidal volume. And also another setting that you need to carefully adjust is PEEP. So now let's go to see what we can do to properly adjust the tidal volume. We do know from the experimental studies that excessive tidal volume injures the lungs, both healthy and previously injured lungs. And this is the reason why clinical researchers decided to test different strategies to reduce tidal volume to prevent ventilator-induced lung injury, or also called VOLU trauma. And these are the first three pivotal trials. The only one that was positive was that by Marcelo Amato and co-workers, where in the two arms there was a huge separation between the two strategies. And after this initial three trials, arrived the largest one today, comparing sponsored by the ARDS network. This is a randomized clinical trials of about 1,000 patients, two arms, one treated with tidal volumes of almost 12 mL per kilogram, and the other arm, the intervention arm, treated with low tidal volumes of about 6 mL per kilogram predicted body weight. And here you can see that in this study, when patients were treated with high tidal volumes, the mortality was significantly higher as compared to patients treated with lower tidal volumes. Here you can see the distribution of tidal volumes in the 20 years ago when the ARDSnet trial was published, and that where this Gaussian curve shows you that the average tidal volumes were centered about 10 mL per kilogram. And what we have seen now over the years is that this distribution of tidal volumes has moved to the left, and this is in the blue curve, the approximate distribution of tidal volumes that we use nowadays. You see that there is not one size fits all volume, but a range of volumes that we administered in these patients. And again, here you can see that the average tidal volumes that are clinically used in patients with ARDS. Again, the lung safe study, the largest one published today, you see that the average BT is about 7.5 mLs per kilo. Later on, we have learned that this other parameter, apart from tidal volume, is possibly very relevant regarding the prognosis of patients with ARDS. The diving pressure, as you know, is the quotient between the tidal volume and the respiratory system compliance, meaning that the lower is the respiratory system compliance for a given tidal volume, the driving pressure, the dynamic pressure distending, the elastic pressure to distend the lungs will be higher. Or the higher is the tidal volume for a given compliance, the higher will be the distending pressure, the driving pressure. And this is important because driving pressure gives us an idea of the pressure which is distending the lungs, because, as you know, compliance is proportional to the functional residual capacity, so the amount of the baby lung, and meaning that the lower is the baby lung, the lower will be the compliance, and thus for a given tidal volume, if we have a very, very small baby lung, we are going to have a very large driving pressure. And what are the implications of the driving pressure? Note the difference between PEEP and end inspiratory pressure. In this study, Amato and co-workers showed that it seems to be a breaking point, if you will, above which the risk of mortality steadily increases, and this breaking point is a driving pressure of about 15 centimeters of water. And even more interestingly, here to the left part of the cartoon, you can see that what is relevant is the driving pressure and not the end inspiratory plateau pressure. Now, I say it differently. For patients with driving pressures 14 centimeters water or below, there is no increased risk of mortality irrespective of the amount of plateau pressure. However, in patients with driving pressures above 14 centimeters of water, there is a clear increase in the mortality risk irrespective of the plateau airway pressure being below 30 or above 30. So this data strongly suggests that driving pressure is a good marker of a good prognostic marker in patients with ARDS. Again, taking advantage of the 50 years of research of ARDS, the 50th anniversary of ARDS. There is a beautiful series of articles published in the Blue Journal regarding the BT, the PEEP, etc., etc. And again, here the authors pointed out that the best approach to set PEEP may involve limiting lung stress and strain or driving pressures as potential surrogates for ventilator-induced lung injury and parenchymal overdistension. And this is what has been finally demonstrate, if we can use this word, or strongly suggested in this study. This is a quite complex analysis of previous randomized controlled trials, including more than 1,000 patients. And here, what the authors say is that when you take the elastance, here the normalized elastance in the horizontal axis, the higher is the elastance, so the lower is the compliance, the higher is the benefit, or the higher is the increase of mortality when you use tidal volumes. Again, here to the right, what you can see is that for normalized elastance is no above 1 or 1.5, no, as long as you increase tidal volume, there is a huge benefit in terms of mortality when you decrease the tidal volume. And again, this data shows, and this is an important concept, that when the elastance is relatively normal, so the elastance is low, meaning that the compliance is normal or in brackets relatively high, the benefits of lowering tidal volume are lost. And in these cases of normal compliance or near normal compliance, patients could even benefit of no decreases or using a bit higher tidal volumes. So this is a strong, a strong message for decreasing tidal volume as long as the elastance is low. And practically speaking, this means that the parameter that we need to control for is at least according to this data, is the driving pressure, which again, is the relationship between tidal volume and the compliance. Now, of course, in the context of the ARDS lungs, lungs that have a huge intrapulmonary shunting of blood, but not only a huge intrapulmonary shunting of blood explaining hypoxemia, these patients also have a high dead space to a tidal volume ratio, and together with the recommended low tidal volumes, this can generate hypercapnia. And where do we have to go? This is still a matter of debate. Hypercapnia is not very good for a number of physiological systems. And in this data, again, observational data, there is a relationship between severe hypercapnia and outcome in patients intubated and mechanically ventilated with ARDS. And if you focus here to the left hand side of the cartoon, when the hypercapnia is severe, defined in this study as values of PaCO2 above 50 millimeters of mercury, the adjusted risk of ICU mortality significantly increases. And when the authors performed multivariate analysis, they observed that the crude, the adjusted, and the matched analysis all went in the same direction, indicating that hypercapnia was associated with an increased risk of mortality. Well, what about the PIP? We do know that the lungs of patients with ARDS are small, and are small because alveoli is no longer filled with gas, but is filled with debris, edema, and the amount of gas inside the lung is small. And to that end, we need to recruit the lung, so open those areas that are collapsed or degassed. and PEEP is used for that purpose, and positive end expiratory pressure has a number of beneficial effects because it avoids end expiratory collapse. It promotes a more homogeneous distribution of tidal volume, thus decreasing the likelihood of ventilator-induced lung injury, especially in the zones of poorly aerated and non-aerated regions. It decreases the cyclic lung opening and closing, the phenomena of atelectroma. It decreases the lung inhomogeneity, and of course improves gas exchange thanks to the reduction in intrapulmonary shunt, and sometimes because of hemodynamic effects due to decrease in cardiac output. And because PEEP in certain circumstances, especially when patients are not properly resuscitated or are depleted of fluid, it can cause hemodynamic derangements, and also PEEP promotes overdistension. And last but not least, we do know from studies conducted with the CT scan, and we see this later briefly, that still a huge amount of lung tissue, up to 24%, cannot be recruited even at high or very high end inspiratory plateau pressures of 45 centimeters of water. And again, what can we do regarding PEEP titration? This is an old study done in a small number of patients. It was a physiological study just to understand the mechanisms of pulmonary gas exchange using the multiple linear gas elimination technique. And in this study, what we did was to compare the baseline situation. In those days, as you can see here, the patients were ventilated with tidal volumes of about 9 mLs per kilogram, and average PEEP levels of 10 centimeters of water. And you can see here that with these parameters, the plateau pressure was below 30, with a driving pressure of 20 centimeters of water. And in this physiological study, we wanted to open up the lung, and to that end, we used the pressure volume curve strategy, and we adjusted external PEEP at a level that was 2 centimeters of water above the lower inflection point of the pressure volume curve. And this resulted in a PEEP level of 18 centimeters of water. And also in this study, by design, we wanted to keep the same plateau pressure as in the basal condition, and thus we reduced the tidal volume. And the tidal volume was reduced to something below 6 mLs per kilogram. And look at that with this, in brackets, open lung strategy, with this high PEEP, low tidal volume, the driving airway pressure significantly decreased in these patients to levels that now we can consider as not harmful. And this is what happened in terms of gas exchange. This is the distribution of ventilation and perfusion according to the multiple linear gas elimination technique. And again, typically you see a huge fraction of shunt in basal condition, a huge amount of dead space, alveolar dead space, which obviously increased a little with the high levels of PEEP. The high levels of PEEP significantly decreased the intrapulmonary shunt, and this was accompanied by a major improvement in arterial oxygenation. And here to the right, you see the second baseline condition, which is almost identical to the first one. And this is essentially what these authors did later on. And this is a large multicenter trial conducted in France, in which authors compared two strategies. One, the minimal distension, which was the usual cure by those days. It was a low PEEP with low tidal volume, and authors compare this usual care strategy with one called increased recruitment, in which not the PEEP, the external PEEP, was increased up to reach an end inspiratory plateau pressure between 28 and 30 centimeters of water in order to maximize the recruitment. Now, when you see the whole data, you see that there is no differences in mortality. That was the main endpoint of the study. However, when the authors split the populations between patients with real ARDS, I have to recall you that this was done before the Berlin definition. So the ARDS was patients with PaO2, FiO2 below 200, and patients with PaO2, FiO2 above 200 were called acute lung injury. Now this is the group of mild ARDS, and this is moderate and severe ARDS. And interestingly here, when you split these populations in the nomenclature or in the taxonomy that you use nowadays, this is patients with moderate severe ARDS, the increased recruitment strategy tends to improve mortality, whereas the opposite is seen in patients with mild ARDS. And here to the right, look at this carefully. These are data from Jean-Jacques Groby group showing patients with diffuse up here and focal down there ARDS with CT scans and with compliance. Here is the diffuse ARDS with inflection point in the PV curve and quite low compliance of the respiratory system. And there are other patients with mild ARDS or acute lung injury with less altered compliance, a more preserved respiratory system compliance, and more gas in the CT scan. And you see why. You see later why I'm showing this slide. This is another study by Brill and co-workers showing that in this meta-analysis, when they grouped patients with, according to the traditional, well, to the Berlin definition of ARDS, patients treated with higher PEEP as compared to lower PEEP, the patients treated with high levels of PEEP benefited in terms of survival as compared to patients treated with lower PEEP. So this meta-analysis suggests that the patients with ARDS are better supported with higher rather than lower levels of PEEP. Now, another way of adjusting PEEP is using the recruitment maneuvers, and this is the trial by the Brazilian group. And in this trial, in which authors used quite aggressive recruitment maneuver, a stepwise recruitment maneuver to titrate PEEP according to the best compliance. The authors treated one group according to this strategy of the stepwise lung recruitment maneuver and adjustment of external PEEP according to the best compliance during the deflation maneuver of the recruitment, and another group of patients treated with conventional or usual care PEEP. And unfortunately, in this study, what the authors observed was a significantly higher mortality in the patients treated according to the PEEP titration after the lung recruitment maneuver. Another also physiological focused way of titrating PEEP is using the PEEP titrated according to the end expiratory transpulmonary pressure, and to perform such a sort of titration of end expiratory transpulmonary pressure, you need to insert an esophageal balloon, which is a surrogate of pleural pressure, and thus, with the difference between the airway pressure and the esophageal pressure or pleural pressure, you have the value of transpulmonary pressure. And in this study, the authors adjusted an external PEEP that gave a positive value of end expiratory transpulmonary pressure. This is the esophageal pressure guided PEEP compared to the empirical PEEP. And here again, no differences were observed in the main endpoint, which was a composite outcome of death and mechanical ventilator free days. You see here that in this study, however, the two ways of adjusting PEEP gave us a result, almost identical median PEEP levels. And perhaps this explains this lack of difference. This is another study conducted in Australia and New Zealand, I think, and Saudi Arabia, and where the authors also wanted to adjust PEEP according to a maximal recruitment maneuver, and this study was aborted because of cardiovascular adverse events. And here the editorialist, looking at this data, these editorialists were quite skeptical about the usefulness of this kind of maneuvers. This is another attempt to personalize mechanical ventilation according to lung morphology, and especially regarding the use of PEEP and also prone positioning. And again, in this study, the authors wanted to split patients between those with focal lung alterations and diffuse lung alterations using CT scans and chest X-rays. And the problem with this study was that it was a huge amount of misclassification when patients were allocated to one group or the other, and only 30% of the patients had CT scans. And in spite of being an extremely good idea, this study overall was negative. A post-hoc analysis of the data showed, however, that those patients that were properly classified tended to benefit from these personalized strategies. However, the use of these radiological tools was extremely complex in the clinical arena. Again, the CT scan in the context of ARDS is an extremely powerful tool. It has provided a colossal amount of new knowledge, and the problem is that the technique is not useful for common clinical practice. So this is we need tools that we can use at the bedside. One that is promising is the use of electric impedance tomography. And in this study, in selected patients that were treated with ECMO, so a subgroup of very severe ARDS patients, authors compared the different levels of PEEP in the intersection of the images obtained with the EIT in just in PEEP in those levels that provided lower collapse and lower over distensions. So trying to maximize the beneficial effects of PEEP. So minimizing over distension and maximizing recruitment. And you see here how different the patients behave among them, thus suggesting that this is a technique that could be useful to individualize PEEP strategies. The same, this is even more recent data. This takes the pressure volume curves during tidal ventilation at 2 different levels of PEEP. I will avoid the details of how to estimate recruitment with these techniques, which we know since more than 25 years. And it consists in decreasing the level of PEEP from a high level, 15 centimeters of water, for instance, to a low level of 5 centimeters of water. See what is the amount of exhaled lung, calculate the recruitment, and then using this quotient, the recruitment to inflation ratio, which is the compliance of the recruited lung divided by the compliance of the baby lung. Here in the colors, blue is the compliance of the baby lung, the compliance of the lung at 5 centimeters of water. And here you can see this ratio of pressure, 10 centimeters of pressure decrease, and this ratio of recruited volume. This gives you the compliance 14 of this recruited lung, and the ratio is 0.4. In this other example to the right, using exactly the same methodology, you have a ratio above 1. And here the author suggested that the ratios above 0.5 suggest the amount of significant recruitment, at least in this physiological study. Now I will finish with some words on prone positioning. We do know that prone positioning has major mechanical advances that minimize the ventilator-induced lung injury. So this is why we think prone positioning is beneficial. And this is the seminal study showing that in selected patients with severe ARDS, with prone position performed early and during a prolonged duration, this was accompanied by a significant benefit in terms of survival improvement in prone position as compared to supine. Again, this is possibly the most recent meta-analysis, and here again we showed that the prolonged position more than 12 hours, and also the I can move on the slide. And in moderate to severe ARDS, the benefits of a prone position as compared to supine are relevant. This is the last review on this topic published some months ago for those of you who are interested in this issue. And now a few words on the controversy regarding whether or not ARDS in COVID-19 is typical or not. And this is the study by Noah Gaccinoni and co-workers showing that in this entity, in this condition, COVID-19 pneumonia, so a single disease, there are different phenotypes, one called the phenotype L, the other phenotype H, and meaning that the phenotype L are patients with low elastance, with low BQ relationship, explaining hypoxemia, low lung weight because the lungs are here, as you can see, not much degassed, and patients with low potential for recruitment because the lungs are filled with gas in the majority of areas. However, there's another phenotype, not the H subtype, which stands for high elastance, so low compliance, a high intrapulmonary shunt, which is produced by this collapsed lung here, high lung weight because all the lung is edematous and collapsed, and there is a very small amount of gas. And this is the reason, again, why compliance is low. And again, lungs with high potential for recruitment. There's, as I told you, much controversy about this, and the authors, of course, propose different treatments for obvious reasons. When you see or you have one phenotype like this, or one phenotype as this other, where the consolidation predominates. No, these two CT scans are similar to those that I showed you by Vieira and Ruby in 1999, showing the focal, where plenty of gas, and the diffuse that were mainly consolidated. These patients benefiting for high levels of PEEP. These patients, high levels of PEEP, really very dangerous because promote overdistension and surely hemodynamic derangements. Again, this is more data from the same group, indicating that indeed, at least in this relatively small number of patients, there is a slight differences when you compare COVID-19 ARDS versus typical ARDS in a matched cohort and matched on oxygenation. Patients with COVID ARDS have a trend to have a slightly higher respiratory system compliance as compared to traditional ARDS. And again, when you matched on similar compliances in these two conditions, COVID-19 and ARDS, at matched compliances, patients with COVID-19 ARDS are more hypoxemic. Again, telling us that COVID-19 disease is a very vasculopathic entity that generates lots of endothelial lesions, not only within the lungs, but also in other territories, due to the specific action of the virus that, as you know, binds to the ACE2 enzyme, which is present in plenty of endothelial cells. However, when we go to the large cohorts, and this is the largest in my knowledge published in patients with ARDS, you see here that the compliance of this whole population is virtually identical to the compliance of the LungSafe study, relatively low respiratory system compliance in patients ventilated with or because of COVID-19. Again, similar mortalities, and perhaps the good news is that there is a sort of renaissance of the use of front positioning in ARDS secondary to COVID-19. This is recent data on a comparative effectiveness of different protective ventilation strategies in patients with ARDS, not COVID. And here you can see that the best strategy is the association of low tidal volume. Low tidal volume defined here specifically in this study below 8 mL per kilogram. This is a colossal study, more than 9,000 patients. And the best strategy in terms of significantly reducing the risk of the relative risk of mortality, as you can see, is the association of low VT and prone positioning. Now, this was again accompanied by an editorial, and we raised a number of comments. And we commented that possibly today, it's more interesting to target driving airway pressure rather than VT per se. That PEEP has to be again tailored according to phenotypes of recruitment or no recruitment. So it makes no sense to put moderate or high levels of PEEP in patients who are not recruitable. And also in some patients, possibly it's interesting to individualize the injury applied into the lung via using the transpulmonary pressure. So just to finish, the support treatment of ARDS patients with mechanical ventilation is to be implemented with settings that provide reasonable gas exchange and above all the complications, and especially the overdistension and expiratory collapse, the atelectroma and the hemodynamic derangements. And today, at least from a clinical point of view, we have to pay some price for it, and there are trade-offs for individual titration, because some strategies may impair some other physiological conditions. And this is my last slide. Some recommendations are mainly recommendations for do not harm, and this is I underline initial settings. And we recommend avoiding pure oxygen because it generates rapidly denitrogenation atelectasis, and keep a reasonable saturation between these ranges, respiratory rate of 20, low BTs to begin. We prefer using volume control ventilation with short end-inspiratory pause, because we can monitor in a cycle per cycle basis the end-inspiratory static plateau pressure, and we easily calculate the driving table pressure. The PEEP, we recommend adjust PEEP in moderate to severe ARDS according to the express study by Mercan and co-workers. So adjusting PEEP, giving plateau pressure of 28 centimeters water, or you do a recruitment test as shown by Lu and co-workers in the American journal last year. In obese patients, we think is important to monitor transpulmonary pressure, and here we adjust PEEP with a slightly positive and expiratory transpulmonary pressure using esophageal balloons. We always keep driving airway pressures below 15. Very important to avoid the indesirable effects of low vital volume, decrease the instrumental dead space. So we systematically use heated humidifiers, and we use only neuromuscular blocking agents when usual sedation cannot abolish drive, and we systematically use proning when the patients are severely hypoxemic or even moderately hypoxemic. And then we titrate according to the individual clinical characteristics. Seems this is an extremely dynamic conditions, and what we titrate what just today, perhaps we will need to change it tomorrow, especially considering all these physiological characteristics down here, such as gas exchange, the mechanics, the hemodynamic status, and of course the patient ventilator interactions. I thank you very much for your attention.
Jordi, that was superb. Really good. I think it was a nice review of the current status, where we are. There's a few questions, but I've written down 2 or 3 just for your hearing your views on it. What are your thoughts on, for example, with permissive hypercapnia, which, in the days when Keith Hickling was involved with this development, and showing a low mortality compared to conventional ventilation, and it was protective, right? It wasn't protective. Now we see there's other complications. Mm-hmm. So what's your thoughts about piggybacking like low flow ECOR to try and make them more normocapnic?
Okay, so 2 things. One is anecdotal. The study that you alluded to by Keith Hickling, it was a seminal study and was published in Intensive Care, and I was one of the reviewers of that paper. And we have to remind that those days were the days of the high tidal volumes as per our standards. And this study paved the way for the reduction in terms of tidal volume. And seeing that, I want to underline this, that moderate levels of hypercapnia are extremely well tolerated and possibly are not harmful. And this is why I've shown you some studies, not only of the ARDS literature in some of my slides by, for instance, David Tuxen in Australia, and also Claude Perret, etc. There are studies and Francois Phil that are studies mainly done in COPD and asthma patients, and we have seen that the only way, and especially in asthmatic patients, to protect the lung and avoid massive overinflation is to allow for hypercapnia. But again, when we go to extremes, physiological systems tolerate very, very, very poorly the extremes for obvious reasons, right? There is always or almost always a U shape. If you put in the horizontal basis no physiological parameter such as PaO2, for instance, a PaO2 of 0, it means 100% of mortality, and also perhaps a PaO2 of 600 is associated with major harm, right? But I think that what we learned from Keith Hickling was that we can manage hypercapnia if we are careful.
And do you think there's a place for like low flow ECOR to try to normalize?
Well, we have the recently published study by the UK group by Perkins and Danny Macaulay, and unfortunately the study is fully negative. It is true that I think that perhaps the problem of this study, it was not the technique, but the design of the protocol, okay? So perhaps we need to know how to individualize the patients. And I am persuaded that in patients in whom in the very beginning they are a severe derangement of mechanics, and these are patients with very low compliance. For obvious reasons, you will need to ventilate these patients with very low BT in order to avoid high driving pressures, because we want to avoid these distending pressures, and this will turn almost immediately in a huge hypercapnia. So I think these patients, this phenotype, if I can say this, could benefit from this technique. But I do not know how many of these patients do we have. This will perhaps require a new design of the study, and of course focusing a different population.
Of course. So we have some questions, Jordi, which I'll read out to you. This is from a friend of yours and mine, Dr. Roland from Peru.
Mm-hmm.
And he asks, how do you recommend to set PEEP before proning the patient?
No, that's a very good question, Rolin. No, I'm happy you asked this. What we do in clinical in the clinical setting, again, is to adjust PEEP according to the express strategy. Okay, so we adjust PEEP to get a plateau pressure of 28 centimeters of water. And now in the last months, because we are cooperating, and maybe you are participating in this study. We are using, but this is a randomized study, say the traditional strategy with the strategy of adjusting PEEP according to the recruitment to inflation ratio. And the idea behind this is to put PEEP in patients whose phenotype is a recruiter, and avoid high levels of PEEP in patients whose phenotype is the non-recruiter. But again, we need to prove this in a larger study, and we will need some time to properly answer that question.
There's also a second question from him as well. So obviously we're liking what you're saying. And the question is there a useful approach to use mechanical power concept in clinical practice?
Which concept? The mechanical power?
Yes, same as Luciano Capannoni.
Yeah, sure. Well, I think is exceedingly complex, and there is again data in the literature. It's true that is not direct comparisons that show that perhaps more simple indexes, such as, for instance, driving airway pressure is good enough. No, it's true that mechanical power is, say in brackets, a holistic issue, and it takes into account not only the elastic load, but also the resistive load, and also how many times do you apply these injurious loads. If we can say these loads, either elastic or resistive, are injurious. But I'm afraid that until we do not compare face to face these two strategies, the one holistic, which makes sense, the mechanical power, because it takes into account, say, everything, or the more simple, which is the surrogate for a small lung, which is the driving airway pressure. Until we do not compare face to face, we will be in circular thinking here. No, and it's true that at the end of the day, people love simple things.
Just like us.
But this is my bias.
Of course. Thank you, Jordi. Now, the second two questions are actually relevant because it's based on esophageal pressure monitoring. And what the first question is, in light of the EPVENT-2 study, do you think there's a place for esophageal monitoring today?
That's a very good question, and I think that there is. And even though the Jeremy Bedler study is negative, etc., I still think that behind there is a beautiful and very solid, not only beautiful, very solid and robust physiological basis. And this is so especially, I think, in obese patients. Titration of PEEP in obese or very obese patients is exceedingly difficult, perhaps because these patients have not necessarily because the compliance of the chest wall is low, because it is not, but because the lungs are compressed because of the huge weight. And then the only good surrogate that we have to titrate PEEP is the end expiratory transpulmonary pressure. And in these patients, we systematically use esophageal balloons, and even we have treated patients with up to 30 centimeters of external PEEP, up to 30, adjusted with esophageal balloons, and keeping the driving airway pressures below 14 centimeters of water. Okay, so I think that the use of esophageal balloon is at least extremely useful in obese patients. And again, for sure, to make the clear-cut demonstration, we would need, at least in this population, conduct a randomized clinical trial comparing usual approach with that provided by esophageal balloons. But,
the next question is, what are your thoughts on pairing volumetric capnography with esophageal pressure monitoring? Is it still relevant?
I think so. I do not. I think capnography is and CO2 in general and that space are physiological parameters that has been largely forgotten for a number of reasons. Now we have a very good monitoring tools, and the answer is yes. No, I think that monitoring capnography is useful, and the problem is how do we integrate the capnography in the rest of monitoring to make a proper and comprehensive algorithm to treat these patients. But yes, the answer is that I think capnography is a relevant parameter to not to take into account in patients with ARDS, for sure.
Another one is based on the use of neuromuscular blocking agents. Patients with high drive, would you large tidal volumes, sedation is not really working. Would you let them breathe on pressure support, or would you just paralyze them?
Well, that's an extremely good point. And again, from a clinical point of view, if your patients are ventilated with unduly low tidal volumes, they will convert in higher hungers immediately. And this is especially true if this is accompanied with hypercapnia. You are going to stimulate your drive enormously. First question that you need to ask yourself before going on pharmacological actions is whether or not the ventilator settings are properly adjusted. And these are settings of PEEP and tidal volume. So if you can increase slightly tidal volume, just do it. If you can increase your level of PEEP to maximize recruitment, just do it. No, if you are within, say, physiological or clinically acceptable ranges. Okay, so do not be obsessed with a single value of tidal volume of 6 mL per kilogram to say a number. Don't be obsessed like this. Okay, just titrate and keep in mind that nowadays, and according to the knowledge that we have, possibly the best parameter to adjust is monitor the driving airway pressure, the difference between PEEP and inspiratory pressure. If with this the patient is still uncomfortable, first of all, ask yourself, if the patient has pain, then you can use painkillers, adjust sedation, and if with common sedation the patient is still fighting against the ventilator, perhaps you can try neuromuscular blocking agents. My suspicion is that patients that after a proper adjustment of ventilator parameters and judicious use of analgesia and sedation are still exhibiting a high drive. I think this is a marker of severity and perhaps of a really severe encephalopathy or some ongoing lung injury. And some of them, to tell you the truth, are extremely complex, extremely difficult. And again, you have to make choices. But we try to avoid especially high doses of pharmacological agents. Okay, because we do know that the patients will later pay a huge price. So we try to go in the low range of all those.
Good point. Good point. An interesting question for you now, Jordi. This is, which ongoing studies do you think intensivists should be looking out for? Anything that's really making an impact?
Yeah. I think trying to, when you say we want to phenotype patients. I think this is extremely important, and it's the same as saying individualized, but we need to be aware of which biomarkers we use to. And for instance, traditionally we have in brackets phenotyped recruitment with oxygenation, and possibly this is wrong, right? For instance, when titrating PEEP, we will need to titrate according to a phenotype of a recruiter versus non-recruiter, and use relatively high PEEP levels in patients able to recruit, and minimize PEEP in patients who do not recruit. And the same for tidal volumes, right? In patients with a phenotype of not really very small baby lung with compliances which are not much altered. Perhaps these patients you can allocate a higher tidal volume, and thus avoid all these problems that your colleague alluded to before in terms of higher hunger, patients that do not adapt properly to the ventilators, that need a colossal amount of sedatives, etc., etc. So there is much ongoing, and in patients in whom, despite all the best possible adjustments you have used in cladding, for instance, not only esophageal balloons, not only CT scans if you have the possibility to use it, or even electric impedance tomography, etc. Perhaps in these patients, I think that the extracorporeal support is certainly a very good option.
Okay, Jordi, one more question, and it's really, in your experience, did you observe hemodynamic impairment after the patient being placed in the prone position, and any reason for that?
Often we do not see permanent hemodynamic impairment when patients are thrown to prone. Again, because of the question that Rolene asked before, we titrate PEEP before proning. When we titrate PEEP, we make sure that the patients are not, of course, not overloaded, but they have enough intravascular volume, just enough, and that way it is really rare observed hemodynamic derangements regarding to the increase in intrathoracic pressure because of PEEP, and the only abnormality that we use, but this is often very transitory, is immediately during and immediately after the turn, right? That is true that during and immediately after, perhaps 5-10 minutes, the patients are a bit more unstable from a hemodynamic point of view, more tachycardic, perhaps because the lines kinked just a little, etc., because the patients are not 100% with analgesia. You have to remind that turning from supine to prone can be a bit painful in some patients. So you have to be sure that the analgesia has been properly administered, etc. So it's rare to observe severe hemodynamic impairment. It's very rare.
Okay, Jordi, one last question, and this is from me, with one of my bias, I suppose, with regard to setting PEEP. We see these lots of studies, negative studies, big numbers of patients, high PEEP, low PEEP, and like you mentioned, there's recruiters and non-recruiters, and what we're doing is jumping in, say, 10 of PEEP, 15 of PEEP, and it's likely a number of them are non-recruiters, like you showed before, and there are patients who are over-PEEPed, and so on. And with regards having a tool like we've done with the Bella Vista, having a lung recruitment tool that analyzes recruitment, do you think that we should be analyzing patients correctly first before we determine their PEEP, as opposed to, for example, doing a staircase approach, maybe looking at the lung closing pressure or the hysteresis of the lung, something else we could do.
Yeah, my bias is that we need to know beforehand how is the lung of your patients before you put levels of PEEP above 10, 12 centimeters of water. No, above 10, 12, I think is high PEEP. No, there is a high potential for harm. And you want to make sure that these patients are really recruitable and really can benefit from these high levels of PEEP, right? And you want to, and again, you want to avoid not the the injurious effects of wrong PEEP settings. So it's possibly that in the old studies, there is a sort of misalignment, right? Because, and perhaps because we have, again, employed a wrong phenotyping using PaO2, right? Because traditionally, this has been used according to PaO2. It's true that recent studies have used the more physiological, such the more physiological study by Baylor that used balloons had no positive results, but we need to understand why this happened and whether or not, again, there is a subtype or a phenotype of patients that benefit. And actually, there is an already accepted paper by his group in the Blue Journal, indicating that in this study, in the EPVENT2, there is a subgroup of patients that really benefited from titrating transpulmonary and expiratory transpulmonary pressures between 0 and 5 centimeters of water. So for sure, there is a place to individualize treatment with PEEP. And now I think that we have tools at the bedside to do this better than we did in the past.
Correct. Well, look, thank you very much again, Jordi. It's really, really good as always to have you with us. I think the audience today has gained a lot. I mean, I think just reviewing a lot of this literature is so important. So, Jordi, thank you again for joining us. We really appreciate it.
Thanks.
Thank you, everybody.
Graham. Okay. Thank you very much, everybody, everyone as well. And thank you, Graham, for your introduction and leading the discussion and all the attendees that asked all of them very, very relevant and pertinent questions. I'm very grateful to everybody. Thank you.
Thank you, everybody.
Hope to see you soon in person. Bye-bye.